Welcome back, everyone, to part 7 of our 15-part Interventional Radiology Coding Masterclass. If you've been hanging out with us for these explainer, you know we're breaking down IR procedures piece by piece. Today, we are cracking the code on catheterization. It's a foundational concept, and honestly, it trips up a lot of medical coding professionals. But by the time we wrap up, you're going to see it with absolute clarity. Let's get right into it. All right, here's our agenda for today. We're going to cover non-selective catheterization, then selective catheterization, dive into the final placement rule, and wrap it all up with a clinical case breakdown. Let's jump straight into section 1, non-selective catheterization. To really build a solid mental model here, I want you to imagine your catheter traveling down the main highway of the body's vascular system. And here's the kicker. It's not taking any exit ramps. You've got your main route, and you're just cruising along it to get a broad lay of the land, completely bypassing all those smaller, more complex side streets. And that brings us to our formal definition. In a non-selective procedure, the catheter never leaves that main accessed vessel, what we call the parent vessel. Now, whether that parent vessel is the aorta, the superior vena cava, or the inferior vena cava, the absolute defining characteristic here is that the catheter does not enter a separate vascular branch. It just stays right there in the main thoroughfare. Okay, moving right along to section 2, selective catheterization. Now, for selective catheterization, we're doing exactly what the name implies, right? We are actively selecting a specific path. We're steering that catheter right off the main highway and advancing it into a branch vessel that extends beyond the parent vessel. So practically speaking, this could mean moving from the aorta into the celiac artery, the renal arteries, or the mesenteric branches, all for highly targeted diagnostic imaging or therapy. The human arterial and venous systems, while they aren't just straight pipes, they branch out into these incredibly complex secondary and tertiary vessels. Think about the visceral arteries carrying blood to the internal abdominal organs. Reaching those distinct vascular families requires active, highly deliberate navigation by the physician. It actually takes work to get in there. Which brings us to section 3, the final placement rule. So, keeping those two distinct pathways in mind, staying on the main road versus taking a targeted exit, how do we definitively choose the right CPT code? Well, it all boils down to one simple, unbreakable, golden rule. Your coding fundamentally depends on the final placement of the catheter tip, period. It really doesn't matter what route the catheter took to get there, it only matters where the journey of that tip ultimately ends. Let's apply that logic to a massive trap that coders fall into all the time. Listen closely because it does not matter what the physician visualizes on the screen. They could inject contrast dye that lights up a dozen different branch vessels beautifully, but for your coding, it only matters if the catheter tip itself stayed in the accessed parent vessel, making it non-selective, or if the physician physically moved that tip into a branch, making it selective. Time to put this into practice. Section 4, clinical case breakdown. Let's take all this theory and put it to work with a real-world clinical scenario straight from an operative report. Here's the setup. The patient is in the angio suite. After some conscious sedation and local anesthesia, the physician uses ultrasound guidance to access the common femoral artery. They thread a guide wire followed by an omniflush catheter. Now, this catheter is advanced and placed into the abdominal aorta. Once it's in position, the wire comes out and contrast is administered using a power injector. Why? To perform an aortogram specifically to identify the level of the renal arteries. Okay, pause for a second. Mentally lock in your answer based on our golden rule. The physician clearly states they're looking at the renal arteries, right? And those are definitely branch vessels of the aorta. So why on earth is this specific scenario categorized as a non-selective catheterization? The secret is entirely in the tip. If we look closely at the operative report, it states the catheter was placed into the abdominal aorta. Period. From that position, they injected the contrast. And yeah, sure, that contrast flowed into and visualized those branch renal arteries. But, and this is the crucial but, the physician didn't actually navigate the catheter tip into those branches. The tip stayed safely anchored in the parent vessel, the abdominal aorta. So because the final placement of the tip never left that main vessel, you absolutely gotta code this as non-selective. If you can remember that the final resting place of the tip dictates the whole shebang, you have absolutely mastered the core concept of today's lesson. It is so important to clearly differentiate between simply visualizing a branch vessel and actually placing a catheter tip inside it. Honestly, nailing this distinction sets us up perfectly for our next session, where we're going to map out these exact pathways by tackling CPT Appendix L and the vascular tree model. Seriously,
How does the vascular tree model change everything we know about coding complexity? Well, next time we're diving into first, second, and third order branches and how those specific vascular families dictate your precise codes. It is going to take the foundation we just built today to a completely different level. Thank you for watching and keep learning with Decode Healthcare with Harshal.